All right, so we've talked a little bit about background on nausea, vomiting, and risk. Let's talk about managing nausea, vomiting now. There's some key principles to keep in mind. First thing is stop it before it happens. Prophylaxis is the most important thing for when we talk about managing nausea, vomiting in cancer patients. We need to be proactive and aggressive in preventing nausea, vomiting from occurring in our patients. We want to use the lowest maximally effective dose and give it prior to chemotherapy. So making sure that we're using enough of a dose to get effect, but not too much that we would get toxicity. Consider the side effects of your antiemetics. Many of your antiemetics are active on dopamine, and so you can end up with some dopaminergic side effects. And that can be especially important in patients on other drugs that can cause those side effects, or maybe in patients with disorders related to dopamine, like maybe Parkinson's disease. Tailor the regimen to the patient, so we need to consider those risk factors and make sure we're taking a look at the patient's specific regimen that they're getting. Don't forget about managing delayed nausea, vomiting. Delayed nausea, vomiting, it can be a big problem with some of our chemotherapy agents, so we can't just have our focus on the acute nausea. And then when nausea occurs, treat it early. It is much easier to treat nausea than it is vomiting. And so if we emphasize with our patients the importance of taking medicine before they throw up, so before they have vomiting, it's a lot easier to treat it. It's a lot harder to get medicine in at home if the oral route isn't available. The only route available to us at home would be rectally, and that's not something we want to have to do. So let's talk about some of the drug options we have to treat nausea, vomiting. For this, we want to go back to the schematic I showed you earlier, looking at the pathophysiology of nausea, vomiting. First, remember, the nucleus tractus soteris is processing incoming signals from the GI tract. And so with those incoming signals, the neurotransmitters that we're concerned about are serotonin, which is 5-HT3, as well as NK1, which is the receptor. Substance P is the transmitter. The outgoing signals that the NTS is sending to the vomiting center are primarily dopamine, neurokinin 1, or substance P, and acetylcholine. From the chemoreceptor trigger zone, we're concerned about outgoing pathways involving dopamine, serotonin, neurokinin 1, or substance P, and acetylcholine. What you don't see here is listed neurotransmitters coming from cerebral cortex. The reason for that is the cerebral cortex is primarily related to anticipatory nausea, vomiting. We'll talk about that separately, but we're not so worried about the neurotransmitter communication between the cerebral cortex and the vomiting center. So we have several neurotransmitters that we have to be aware of. So you see serotonin, substance P with the neurokinin 1 receptor, dopamine, and acetylcholine being our important targets to keep in mind. What I'd also like to highlight is the vomiting center. Your primary signals coming out of the vomiting center are dopamine and serotonin. The importance of that is when patients are actively nauseous or vomiting, so you're not so much looking at prevention anymore, you're thinking about treatment. The drugs that are most effective for treatment will work on those outgoing signals. The drugs that work on those incoming signals coming into the vomiting center will help, but because they're working on the signals coming in, they frequently will need a little more time to work.